We might open a discussion. Is anyone going to ask some questions to our speakers? So maybe I would have a question for Dr. Chen. So can you explain a little bit better? Because there is such a good correlation between CT appearance of pure ground glass lesions and pathology. What is the advantage of having a frozen section?
I think it is a very important and very good question. I think you can see the ad-pretty review. We published hard copy just last month. We see that, this is published in 2016 in JCO, and JCOG 0804 published 2022 in JCUS. After that, a lot of the surgeons asked why we need to do intraoperative frozen section until the JCOG 1211 published. JCOG 1211, according to the CT image, assume that invasive adenocarcinoma. And the final result is over 58% and turned out to be AIS-MIA. That means the CTR ratio between 0.25 to 0.5 is not complete. It's not, can predict it. That's invasive or non-invasive. But less than 0.25, 0.804, the result, 38% turned out to be invasive adenocarcinoma. So even the invasive adenocarcinoma, you do the value section, it doesn't matter. But JCOG 1211, in almost 50%, you overtreat it. Just, we cannot, we do another study to use the new classification and use the HRCT to predict the how serious of the disease. So if less than 1 centimeter, 97% accurate. Greater than 2 centimeter, 97% accurate. Between 1 and 2, the accurate rate only 70%. So for you cannot predict that well. So for the section, just help you avoid overtreatment for this kind of patient.
Okay, thank you.
Thank you. Because there is only one pathologist in this floor, so that I would like to ask about some of the questions for the interoperative section for the GGO regions, because the frozen section is quite, is not so accurate, even in lymph node metastasis, to submit the lymph node interoperative sections. So a certain percent of the false negative or false positive has been happened. And also the frozen section is not appropriate procedure to examine the invasion of the adenocarcinoma. If you submitted a specimen to the interoperative section, so we cannot get the correct specimen to analyze that tumor, whether that tumor have invasion or not, because the fixation is quite different, and also therefore the JCOG did not use the intrapulmonary section to determine invasion or not. So we predict the invasion using a CT image.
Yeah.
So, and also I don't think many pathologists don't want to make a decision of whether the invasion or not with the intraoperative frozen section. That's our field.
Yeah, I think that very important, at first, in the AHS annual meeting at first, even in the Jessica Dunning's editorial, maybe in just a few center they can do the intraoperative fluid section. And this is why, we published that paper in 2016. A lot of, just question this, give a lot of doubt. So last 3 years, we did multi-center study to verify intraoperative section accurate or not. We'll publish the data soon. We just get the data done. Over 600 patients in 7 different level, not just your biggest center, your femur center. A different level of hospital to do that study. Actually, the accurate rate still more than 60%, 90%. We'll publish the data soon.
Okay. How did you prove that tumor is really adenocarcinoma in situ or minimally invasive adenocarcinoma without the permanent sections?
Yeah, that I'm certain, yeah. Our pathologists, they did that study.
So because of the JACOB study also conducted intraoperative section to determine this patient should be that's kind of the randomized study is conducted. However, it was stopped because of it's quite difficult in terms of the feasibility for the pathologist. Just my comment.
Yeah, I've been in your center, just 1 month ago. I understand that. According to the CT imaging, based on the JACOB 0201, and I think that's a field study. Just the subgroup analysis give the definition of size and the CTR ratio. It's not the whole study try to answer the question, but just the subgroup analysis give the definition. So I think, there's still something to improve.
Okay, I think in the interest of time, maybe we should close the session, I'm afraid, because if you have questions for the speakers, you can approach them during the coffee break. And so thank you very much, everybody, for attending.